Good morning or good afternoon, everyone. My name is Cristina Sancho, and I'm an Associate Professor of English and the Director of the Humanities Research Center at BCU. My role today is to introduce today's moderator, Dr. Christine Shin, and to turn it over to her to introduce the panelists for today's panel, Coughing and Scoffing, Inequities in the Time of COVID-19. And because this is the last panel of this academic year, I'd like to take a moment to thank everyone who made this series a success and to say that we at the Humanities Research Center are looking forward to future collaborations to bring together scholars and practitioners on our two campuses, as well as community members. First, we'd like to thank the audience. Many of you have attended multiple events. We've had hundreds and hundreds of participants since we started this year. We held our first event in October of the academic year called Fundamentals of Race and Racism, followed by Race, Space, and Power in Richmond, Virginia in November, and Medical Research and the First Heart Transplant in the South in March this year. And either Logan or Ronnie, who are behind the scenes here, I'd like to thank them as well, will post some links to those if you haven't had a chance to attend them. All the recordings are available on the HRC website as well as on the History and Health website, along with their respective learning modules. We'd also like to thank Dr. Art Kellerman for introducing the program over a year ago and for his continued support. The History and Health Racial Equity Steering Committee, Cheryl Garland and Kevin Harris, who are also here today, for their continued leadership, as well as Logan Vetrovec and Massey and Rani Sisavat for all the planning and administrative support. We thank all the moderators and the panelists, as well as the VCU students, because they were the driving force behind this program. The Humanities Research Center and our affiliated faculty, researchers, and moderators who have helped shape this program look forward to continuing this important work and cross-campus collaboration. And before I introduce Chris, just a heads up, an announcement from Logan. In September, we plan to hold the History and Health Racial Equity Symposium, and our programming next year will focus on healthcare quality and access, which will align with the Common Book programming for next year, which is Chip Jones's Organ Thieves. So next up, I'm delighted to introduce today's moderator and my dear colleague, Chris Shin, who is an associate professor in the Department of Gender, Sexuality, and Women's Studies. Her research centers on epidemics as they make visible and exacerbate social, political, and economic conflicts. Besides many articles in top interdisciplinary journals, Dr. Shin has published a book on HIV prevention policies in West Africa titled Prevention, Gender, Sexuality, HIV, and the Media in Côte d'Ivoire, and co-edited a collection on literary and visual representations of HIV/AIDS. Her current book project, tentatively titled AIDS Archives, A Witness of My Time, examines alternative archives, of HIV/AIDS that challenge traditional archival processes and practices. Without further ado, welcome everyone, and I'm turning it over to Chris.
Thanks so much for that introduction, Christina. Hello and welcome everyone. Thanks so much for joining us during such a busy time. Many thanks to the Humanities Research Center and to the VCU Office of Health Equity for hosting this event. I also want to thank panel members who made time in their busy schedules to join us today. Some of us are zooming in from places where they hadn't anticipated being, so thank you. Regina H Boone, an award-winning photojournalist for her family's newspaper, the Richmond Free Press. Cheesy Farmer, a retired UPS employee and owner of and master barber at RVA Clippers, as well as board chair of Diversity Richmond. John Powers, an associate professor and chair of the Department of History at BCU, and Melissa Varay, the acting director for the Richmond and Henrico Health Districts and a board certified infectious diseases and internal medicine physician. So as a new coronavirus, not previously detected in humans, COVID-19 has posed many biomedical challenges. It also has generated debates around public health. The COVID-19 pandemic in the US converged with anti-racist protests following the murder of George Floyd, and demands for social justice informed fierce controversies about its origins, effects, and modes of transmission, prevention, and treatment. We are here in the spring of 2022, not quite in the state of emergency that COVID-19 induced for the past 2 years, but as we brace for another potential wave, the pandemic is certainly not yet in the past. So this conversation offers an analysis of events as they continue to unfold, and at the same time, a provisional framework of how we might productively proceed. The panel will explore how and why certain individuals and communities in Richmond, Virginia have been and continue to be disproportionately impacted by COVID-19. How might we work together to effect some of the transformations necessary to reduce health inequities and resulting health disparities? We will begin with a 45-minute panel discussion and then open up the event for questions and comments. Please feel free to write in the chat during the talks, and please be sure to fill out the very short electronic survey at the close of the event. So to start us off, Regina H Boone, from your perspective as a photojournalist for a Black-owned Richmond paper with a community service and social justice mission, how and why have Black communities and others been disproportionately impacted by COVID-19? How does COVID-19 lay bare some of the inequities that contribute to health disparities and intensify existing inequities? So this is
So hi, good afternoon. Thank you. I'm just going to take it from here and kind of answer that question, but and also show you some work that I've done that sort of just shows you who I am and where I am and what I've seen throughout this period. So as a Richmond Free Press photojournalist, I documented and continue to document the effects of COVID-19 and all the variant viruses that impact our community. COVID-19 has shone the brightest spotlight possible on racism and poverty for not just our city, but globally, as we all know and have experienced. Food insecurity and access to medical care have historically been an issue for Black and Brown people, but COVID-19 has certainly exacerbated these challenges. Since March of 2020, my colleagues and I at the Free Press have documented with words and pictures the ripples of the pandemic that continues today. Our coverage has not and will not stop as it relates to the pandemic. We will always be a place to find pertinent information on our front pages, including where to get a test or a vaccine in the city. Our readers know we are a trusted source in the community. So from there, I just wanted to kind of take it to what I do as a photojournalist. I couldn't just come here and talk to you. I need to show you some of the things that I've documented since the beginning. And you will see, it's just going to be a slideshow that runs, and you'll see various photos that kind of just from the beginning, from signs to people with masks, to tests, to politicians, to the health department, to the food insecurities, to home insecurities, just all the different things that we have covered at the Free Press. And including at one time, we were doing front porch portraits of people, and just so that we were interacting and people could see each other. So let me share my screen.
Thanks, Regina. I'm excited to have conversations about some of those images.
Yeah.
About the role of photojournalists during the discussion session. Thanks. Okay, so we're now going to shift to Cheesy Farmer. Can you offer some insights from your work as a business leader and activist about COVID-19 and how different and overlapping communities have come together to address its impact? And what kinds of broader transformations are necessary to reduce and address the disproportionate effects of COVID-19 on already marginalized communities in Richmond? Thanks, Cheesy.
Thank you, Chris. COVID-19 for Diversity Richmond has brought social and racial injustice and inequities to the forefront. It has highlighted where people of color are more likely to get sick and die during this pandemic. Even in the LGBTQ community, people are vulnerable to the pandemic, especially where the status intersects with poverty, such as the homeless LGBTQ youth and Black trans women. Even in our Latinx community, there's food insecurity. During this time, Diversity Richmond put together food drives as we partnered with Feed More and Stonewall Sports, Black Pride RVA, and other communities and other organizations in the community. We also had set up COVID-19 testing. We also set up an event hall for vaccine clinics. I myself at RVA Clippers partnered with the city of Richmond and Henrico County to do a nationwide, part of a nationwide shots at the shop, which was presented where all the barbershops that wanted to participate in the whole United States, we set up where they would come out and just do the vaccines for us. And then, and Diversity Richmond being part of the LGBT community and having the community center, which is, we consider, a center of the LGBT community, that we just wanted to be a voice and a place and a resource and try to help the community in any way that we could by doing the food drives and by partnering with other organizations and the health department to just, just to be there and let the community know that we're there. Because a lot of times people of color don't have the same resources as others. So we just wanted to be a part of that. Thank you.
Thank you, Cheesy. I'm also looking forward to learning a little bit more about some of those efforts during the discussion session. But for now, we're going to turn to VCU historian John Powers, who can help us situate COVID-19 in the context of prior pandemics. How would you relate some of the inequities that COVID-19 has made more visible and intensified to prior pandemics? And what kinds of social struggles and transformations did these pandemics produce? And how might this history help guide us in the present?
Thanks, Chris. Well, when I heard this question, I immediately, for a historian of medicine, went to the obvious choice, which was to look at the 1918 flu pandemic. And I'll get to that in a minute, but what I want to say first is what's important to realize is that the health inequities that we see in the current COVID pandemic are a long-standing issue in the history of the United States. For example, in the decades before the 1918 pandemic, one of the big issues among public health officials was the fact that African Americans perished at a rate 2 to 3 times greater than whites did for diseases like tuberculosis, pneumonia, and what they called at the time diarrheal diseases. There was a tremendous debate in the public health community about why that was. For supporters of the African American community, the most prominent being the social scientist and activist W.E.B. Du Bois, argued that this was simply an indicator of social conditions among African American communities, and that with more investment and improvements in sanitation, in education, in greater greater economic opportunities, that you would see these rates of infectious disease go down. But on the counter argument to that, which was very much a mainstream belief among white physicians and white public health officials, the higher rates of disease among African Americans was seen as evidence of racial inferiority among African Americans. And my first point here is really that even though we've come a long way over the previous 120 years, there are still bits of structural racism, bits of belief, you might even call them superstition, among the general populace, even among the medical community, regarding this sort of old, now completely debunked, racialized science. Just to give you an example, it was a common belief around the turn of the 20th century that African Americans felt pain in a way that was different than white people did, that they were less susceptible to pain. Scrolling up 100 years, I'd just like to point everyone to an important study that came out in 2016, published by researchers at the University of Virginia, that showed that belief that African Americans suffered pain in a different way than white people did was built into the way that doctors were prescribing pain medication for their African American patients, and was actually held as a not uncommon belief among medical students at the same time. So there's a sense where these older, really debunked beliefs continue to linger on. My second point, again, scrolling back 120 years, is the nature of racial segregation, not only in the South, but also in the North as well. There was very much a differential access to healthcare between the African American community and most white communities. Here in Richmond, most African Americans would be denied care if they were to come to a hospital. And that was even the case in the North as well. So one of the things that local African American communities did was that they set up their own, you might call it, parallel health system. In Chicago, for example, in 1891, a physician named Daniel Hale Williams established the first, what we now call, Black hospital. That is a hospital that admitted African American patients, that also held a nursing school, that also accepted Black doctors, giving them a place where they could, for example, complete their medical education through internships and so forth. And that this became a very popular a way to provide healthcare and also education, which is important because you can't have good healthcare without trained medical personnel. That this movement spread throughout much of the United States, and even here in Richmond in 1920, we are represented by St. Phillip Hospital, again founded in 1920, and its famous nursing school, which taught something like 600 and some African American nurses before it was closed in 1962. Really, the issue going into the 1918 plague were these two things: the sort of segregated nature of access to medical care, and also the sort of racial theories that were held by the medical community. What's interesting about this in the 1918 flu, because I was expecting a story that was similar to COVID, where rates of infection would be so much higher in the African American community. It turns out, however, that according to most sources, the rate of infection in the African American community was actually lower than what it was in the white community. And I was scratching my head and trying to figure that out. And it turns out that probably the reason for that was segregation. That the 1918 flu started primarily, for example, in Richmond. It was clearly brought to Richmond by soldiers in Camp Lee, from Camp Lee down near Petersburg, and that they were mainly white soldiers. And what white families would do for the soldiers training there would be to invite soldiers to their homes for Sunday dinner. And so that became a very easy transmission route for an epidemic that was starting in the camp to be brought into the city, specifically in the white population. And because of separate medical facilities, the African Americans in Richmond and elsewhere in the United States experienced lower rates of influenza infection. Now, what is interesting about this is that even though this tended to fly in the face of arguments that African Americans are somehow inferior because they get sick so much more frequently than white people do, this had absolutely no effect on the status quo in terms of, again, the medical segregation of the races in the North or the South, and had very little impact on different thinking regarding racial theories about African Americans, medical theories, that is. Anyway, I guess that's all I have. Thanks for giving me my 10 minutes.
Yes, it's particularly impressive that everyone can take on these topics in 10 minutes or less. So we're now going to turn to Melissa Beret. As acting director for the Richmond and Henrico Health Districts, and as an infectious diseases and internal medicine physician, can you offer some insights on health inequities and disparate outcomes of COVID-19 in Richmond? How has COVID-19 reproduced and intensified these systematic and structural inequities and disparities?
I'm really hoping that I'm not going to be the one to break the 10-minute rule.
We have a bit of time. You can go a little bit over.
Cross fingers, cross fingers. Just like everyone else has mentioned, COVID really starkly highlighted existing inequities in Richmond. And I think it's worth painting, I know this is not news to many folks in this virtual room, but it's worth painting a bit of the picture into which we introduced COVID from the public health equity lens. So if you have on top of the existing cultural norms that sit within that John Powers mentioned, we have racist policies like redlining that existed that prevented a lot of Black families in Richmond from establishing and passing down any generational wealth, and established these areas of concentrated poverty and limited opportunity specifically within Richmond, but elsewhere in the US as well. And although progress has been made, we nationally poverty rates in Black and Latino families were at lows in 2019, but still twice that of their white and their Asian counterparts. From a health standpoint, we still, pre-pandemic, we were still looking at incredible inequities and from poverty and from institutional racism, with significant impacts on healthcare access and chronic disease management. People living in poverty may live in food deserts. They may have fewer transportation options, leading to increased difficulty in accessing healthy foods. There may be barriers to having opportunities to participate in healthy exercise and activities, like lack of childcare, non-permissive work schedules, multiple jobs, neighborhoods without resources, no green space, no sidewalks, no tree canopies, and being priced out of more affordable options. And then there are also similarly barriers to access to healthcare or management of their health conditions, meaning same thing, lack of paid time off to go to the doctor, transportation issues to not permit them to go to the doctor without paying excess fees or taking time off to take the bus. And then expense or perceived expense of going to the doctor. And then on top of that, experiencing individual systemic racism, I think in and of itself can provide a chronic stressor, which can take a toll on individuals' health. We know that the impact of adverse childhood experiences has a well-documented and known adverse effect on long-term health outcomes. So all of this contributes to perhaps a disproportionate burden of chronic disease and perhaps less access to healthcare within areas of poverty, and specifically for our Black communities in Richmond. So into this milieu, you introduce a novel respiratory virus that is more deadly than influenza that comes around seasonally. And then we have initial efforts to combat and contain the virus with lockdown, isolation, and quarantine, which really did present challenges for our communities of color. So to live into that sum for specific examples, we saw a lot of heartbreaking situations as we were talking to individual cases, trying to talk to folks about, hey, can you stay home? Are you able to stay home and stay away from everyone in your family? And, but we found that there's a disproportionate number of individuals who did not have the ability to take sick leave for themselves or for their kids. They risked their impact. They risked not being able to pay their rent, to pay for their kids' foods. We found a disproportionate number of individuals in frontline occupations, and then you found lockdown where restaurants were closed, frontline occupations were closed, and then that a lot of construction stopped, and so they weren't able to earn income. They couldn't, again, coming back to, are you able to bring food into your home? Are you able to have a stable home to live? Are you risking being evicted from your home because you can't pay rent, because you can't work? We saw multi-generational households, and specifically within our Latino community, but also in our Black communities, and insufficient resources to isolate or quarantine. So for example, if you are the primary caregiver for your children, and you are the only caregiver for your children, it's very difficult to isolate from your kids because there's no one else to care for them. If you're also the caregiver for grandma, or if grandma is the primary caregiver for the kids, it's very difficult to isolate and quarantine should you become infected or should you be exposed to prevent them from getting infected. And so that makes it very difficult for individuals to make these choices to say, I'm going to take this excess income that I don't have to go get a hotel and somehow find a way to have my kids cared for so that they're not potentially infected with COVID-19. And then on top of that, we had no schools in place because everybody was homeschooling. So you had to homeschool your kids. You might not have childcare support, which means you might not be able to have both parents. If there are two parents, not everybody can go back to work because you had to make choices. And those same transportation and childcare limitations also meant that perhaps, and a lot of resources being closed meant that perhaps you aren't able to go get your routine healthcare. Maybe you are unable to take time off to go get vaccinated because you have to take time off if you're sick. You have to find someone to take care of your kids. You have to find transportation to get there. All of these little barriers or big barriers actually added up. And in particular, in our communities of color, we just saw that really play out in a really stark way through this pandemic. And just to add one more thing on top of this, I see my mouth's really dry. One more thing to add to that is that I was just talking about all of the reasons why in communities of color, we may see a disproportionate number of chronic conditions that might not be as well managed because there's less access to care. Add that as potential risk factors for severe COVID, right? And so all of this coming together is not a perfect storm, but a pretty catastrophic situation for our communities. And so it's really a setup for a lot of the worst outcomes for the most vulnerable communities in our city. And let me add a little more to that. So we know a lot more about COVID now than we did in 2020 or 2021. But as we know, this pandemic has been fraught with uncertainty, fraught with ongoing change, and experts disagreeing about what the next right path is. And yes, that is how science happens. That's, the discourse of science is we are supposed to disagree and use the best evidence. It was much more visible for this pandemic. And I think it caused a lot of uncertainty in the public. And in particular, because those disagreements directly impacted their lives and what they were able to do with their lives or not do, as it were. And so hearkening back to the things that John Powers was mentioning, add that uncertainty to this context where medicine and the US government, including my own agencies, have really compromised or not really built the most trusting relationship with these communities. Or perhaps we have not actively engaged and become a part of these communities in a lot of parts of this country. It makes it a really challenging thing to build trust in the midst of all this uncertainty and fear. In particular, as we're trying to make recommendations around containment, around isolation and quarantine, testing, and vaccination. So it's kind of a two-hit, you have limited, your infrastructure makes it harder for you to even do it. And it's hard to know who to trust when you've got these folks coming on board. And so looking at what that meant, I'm just going to share a couple of slides here. See if I can find this up. Just give me a thumbs up if you are able to see those slides. Great. So looking right here, what we have are, looking at the slide. Early on, what we found, one of the first things that we found in this pandemic is that, our Latino population makes up about 7% of the Richmond City overall population. In that first summer of 2020, we saw a whopping nearly 40% of our cases coming out of our Latino population. Overwhelming. And we actually, we ended up calling in CDC. We had a big task force around this. And what we found was that this disproportionate impact has everything to do with those factors I mentioned above. There was an issue of trust. There was an issue of lack of access or connectivity. There was an multi-general households. There was an inability to isolate and quarantine without impacting your ability to bring food home. There were people who, when they were isolated, were unable to find food or ability to pay rent. And all of this meant that there was just a really huge hit to one of our more vulnerable populations in Richmond right up front at the start of the pandemic. Moving onwards, we found throughout this pandemic the well-known disproportionate case burden in our community, in our Black communities. What we see here is this is cumulative over the course of 2020 to now, our race ethnicity distribution in cases in Richmond City. So in orange, you have our population, the percent in the population. For example, again, Latino is about 7% of our population here in Richmond. And in teal, you have our cumulative, and in dark blue, you have what's been going on the last 4 weeks. Last 4 weeks have been particularly, I don't want to say the word, but have been a little lower in case number. And so we see that a lot of noise in the numbers because of that small number. But what you see, despite, if you look across the pandemic, despite the fact that 47% of our population here in Richmond is Black, it still is more than half of our cases. And that disparity, that inequity, actually, it may not look that bad. It's not great, but it doesn't look that bad. But if you take that out to hospitalizations, you see 47% of our population being Black, but 67% of our hospitalizations being in people of color or being in Black folks, and then 64% of our deaths. That's a whopping disparity, and that's a whopping gap, and really just speaks to all of those things that I laid out before, plus this new virus being a more virulent and more severe virus than something we've seen come through. And certainly other factors come into play. I just wanted to show you this as background. This is just a background slide of what we call CDC Social Vulnerability Index, which is just kind of a metric that you have probably discussed before in terms of a metric of different factors that impact one's ability to respond, in particular to an emergency, but also is a good metric for access, transportation, and overall ability to respond to a new thing or an emergency within your home, just like COVID. And while there are other factors that come into play here, this is a picture. Pay more attention to the pink bits. Let me explain. The darker bits on this SVI map are the higher the number, meaning the more vulnerable your community is, the darker the color. So what you see here in Henrico and Richmond is that you see this very dense, you see on the east end here in the north side, and then down here in the south of Richmond, you see a lot of vulnerable populations. And while this didn't play out one-to-one, when you look at case burden, this is a heat map of case burden across Richmond and Henrico from the beginning to the end to now. Beginning of the pandemic to now. You don't see a one-for-one alignment, but you do see there does seem to be trends where you see higher numbers of cases in areas with lower social vulnerability. Oh, getting ahead of myself. And I think the thing that can still be impacted now, where we're seeing disparities, is actually in vaccine uptake. Black Richmonders and Henricoers are the least vaccinated racial ethnic group in Richmond, with less than half of our Black population having received at least one dose of COVID-19. This is a map, this is a chart of our vaccine uptake in Richmond City, where I've outlined here our Black community, where we have our at least one dose in teal, fully vaccinated in orange, and then our booster population in blue. I was very briefly able to say that more than half of our Richmonders had received at least one dose, but that's since fallen down with of eligible Richmonders had received at least one dose, but that has since fallen as we have particularly poor uptake for vaccine in our Black 5 to 11-year-olds, and to a lesser degree in our 12 to 17 or 18 to 20-year-olds. And even more alarmingly, and this is something that we can still impact and is very important, because as we think about the fact that there is a higher case burden, a higher hospitalization and mortality rate that we're seeing in these communities, the fact that we are seeing less uptake is still an incredible concern. And we have engaged with the community. We had community outreach. We have gone through our Black community, our faith leaders, and folks like Cheesy Farmer and Diversity have been, and community partners, Sacred Heart for our Latino community, have been incredible movers and shakers in getting vaccine uptake. But there is just a lot of difficulty in increasing our vaccine uptake within these communities. This one lines disturbingly well. So what we have here is, again, that's that SVI, that social vulnerability index, in green, again, where you're most vulnerable are in your darkest green. And in these blue outlines here, you see lower vax uptake. And what you do see is a pretty clear speaking alignment between your high vulnerability and your low vaccine uptake. Now, to some degree, we've also tried to get at this through having mobile clinics for vaccine. We've tried to deliver, we've got doses on demand. We had South Side clinics, we've had East Side clinics. We partnered with VCU to vaccinate at the VCU hub. It's continued to be a struggle for us to really get vaccine uptake. And when we ask why, when we have our community outreach ask why, because it would be very easy for me to say, oh, it must be access, right? It must be access. And that's on us to get access. It's the combination. Earlier in the mid 2021 area, what we found was that it was a combination of either inability, like, again, do you have childcare? Can you take the time off? If your child has symptoms, or if you have side or symptoms from the vaccine, are you able to take that time off? Are you able, plus issues of distrust in the vaccine, what we've been hearing about the safety around the vaccine, a lot of about the speed of its manufacture. And so we also know that COVID exacerbated a lot of existing inequities. Stay-at-home orders, like I mentioned, virtual schooling, all of these things have just complicated existing issues around food access, stable housing, managing your chronic health conditions. Folks were afraid to go to the doctor even if they needed to. So we saw a lot of routine healthcare visits drop off. And then with surges, people were less able to get to healthcare or to the hospital. We saw childhood immunizations go through the floor. So many children are behind on their routine childhood immunizations because people aren't going to the doctor anymore because they've been on lockdown. They've been on, we've been in COVID land. And so it's just really just exacerbated existing issues. And then on top of that, there's the personal loss that a lot of our community has experienced. I will tell you that the stories that we would hear about whole families, mom, son, grandfather, multiple members of a family dying from COVID, it takes its toll, and it has a very profound and lasting effect on the community and on these families. And so it just adds to the burden and to the impact on our communities. That's not to say that there isn't silver lining to this. I feel like I'm ending on a really dour note. To be fair, as was mentioned, there has been more overt discussion about race and racism as a public health issue over the last couple of years, kind of alongside this. And I feel like that is something that will continue and is something that brings us hope. Our strengthened and new community partners and organizational partnerships that developed in the crucible of this pandemic for public health are things we can leverage for moving the needle for social determinants post-COVID. And there has been a shift over the last 15 years to understand and improve these underlying factors. And now we can leverage these partnerships to really try. And now that we're out of emergency land, I hope for the long term, we can go back to and return our efforts to leveraging these partnerships that we've developed, that we've strengthened with COVID, into trying to move the needle, not just at after these chronic conditions have occurred, after someone is unstably housed, but at the issues that impact them so that future generations don't necessarily have the same outcomes. And we've also, I feel, learned the value of I feel like we already knew this in public health, but we are learning it. It is being even more emphasized, the importance of community members and their lived experience, and having that inform what we do is absolutely critical to not just building trust, but to having implementations that actually make a difference to the community and actually address the needs that they feel that they feel exist, as opposed to what we think their priorities need to be. And so letting that be the driver, as opposed to us deciding for them, us being public health as a whole, not just me, having the community be the driver of what are we seeing and how are we feeling about what we see, has just been really lifted up through COVID, and I hope continues to be a driving voice, not just here in Richmond, but across Virginia and across the nation. And I know I definitely went way over 10 minutes, but I had a lot to say. I'm sorry. That's what I had for today.
Thank you so much. Thanks to everyone for these really generative presentations. I wanted to open it up to audience members who had questions. We have a comment. We saw the social and health disparities literally embodied in the ICU during COVID, and it was horrifying. So many of my fellow nurses are intensely engaged in listening and wanting to advocate because of this. Several of us are on here listening and wanting to influence change. Is it possible to get these slides? Yes.
Yeah, absolutely. I can send them, if you don't mind, if I can send them to you, and then you could share them with King Chat.
Thank you so much. Are there other questions? Great presentation. Do panel members have questions for each other? Because then I of course have lots of questions. So, okay, here, I'm from Luna. Do you think the pandemic has shined a light on the disparities that people of color face? I believe that there were a lot of issues that weren't first priority until the pandemic started. So do you see a shift in terms of perceptions or conceptions? I think is Logan's question, if I don't misunderstand it. So these issues weren't actually priorities until the epidemic?
I think they weren't priorities for everybody. And, I can't speak to the nation as a whole. I don't know if they're priorities for everybody now. I know I think it's been a dramatic enough presentation that perhaps for some of us who, I feel like we've been trying to bang this drum about social determinants for many years, but I don't know that it necessarily people are much more receptive now, I feel, to what it means and how that plays out in health outcomes than I feel like they were before the pandemic. But that could also just be, my impression.
I think from my perspective at the Richmond Free Press and as a photojournalist, that all of this was already here. And so, as we've all said, right? And it's shown a brighter light. But I think where we are at this moment, there's a lot of people and a lot of groups that talk the talk before, like 2020, 2021, but now it's not the topic of the day. but this is our topic at the Free Press. This is your topic, Dr. Beret, right? So we are not going anywhere. We are not going anywhere, and we were here before. But there are groups that found that, oh, we got to get on this, right? And we've got to appear that we care, and we have to appear that we are saying all the right things. I mean, so I don't know.
I think there is now one of the limiting steps, I think, for movement has always been funding. And one of the, perhaps the silver linings to the hideous outcomes that we've seen is attention and funding. What I hope is that in both on, for example, whether it's ARPA and use of ARPA at City of Richmond to fund a health equity trust fund, whether or not it is how, you know, attention to affordable, how, well, that might not be, well, it's COVID related. I think it's COVID related.
Yeah.
I think that funding, funding, attention, and funding means attention. And I feel like I hope that this funding isn't short-lived, and that we are able to, or one of our hopes is to be able to use this, even if it is short-lived. We can't guarantee what the attention is going to be. Use it to build things that will be sustainable, or that we can use to justify getting more funding long-term, to be able to make more long-term changes. So what, you know, if the grass is green now, if the sun is shining, let's make hay. Let's build programs. Let's start putting things in place with this funding that we perhaps had to struggle for before. We really had to fight for what we got. And so if there's funding now because COVID has, you know, highlighted a lot of inequities that people weren't paying as much attention to before, let's make hay. And that's kind of what we're doing at the health district, is that we're trying to make inroads into program and or implementation and our policy where we can, all right, let's say the funding disappears tomorrow, we still got this and we can keep rolling.
But when it comes to funding also, I think it's important that, yeah, that the funding's there, but that the same people are not being funded, the same groups. Because when I'm out on the streets, I'm hearing like, how do I get funded? How do I get access to, let's say, the community foundation or this foundation? How do I get that money? You know, and that is what I think. Yeah, I think people who have smaller groups and smaller needs, they now also are aware on the flip side that there is money out there, but the problem is, how do they get it? And
the connection. Mm-hmm.
Yeah, and that is a big problem that I hear about as someone who is on the streets and talking to everyday people from all different backgrounds. So that's just one thing I'm hearing.
We have quite a stream of questions now, so I'm wondering if maybe we can consolidate some of them, ones that intersect a little bit. So there's a question about to what extent would racial disparities in COVID be improved by the simple but challenging implementation of affordable housing, which relates to continuing steps to close the disparity gaps in RVA and to continue conversations into actionable results. And then what is being done to address the social determinants of health among minorities. I think maybe we can cluster around that those questions. We can cluster the questions.
I want others to talk to you because I feel like I talk a lot. But I will talk if no one else does. A couple of things. It's hard to, I think, like Regina mentioned, this is not new to what the work that we're doing is not new in social determinants, and whether it's building collective impact on, so not just the health district, for example, oh, we're doing a thing. We're not it. We're not the only. And so, for example, if it's something like affordable housing, I can't say the proportional, the attributable impact it would make. I don't know that. But we know that unstable housing, food access, or housing security, and affordable housing, food access, and the built environment all play really big parts of your ultimate outcome, right? Your ability to live, play, work is deeply impacted by these things. And so one of it's a combination of community-based organizations, health district, city organizations, county organizations to look at and it looks different in different locations is what I will say, but there is an effort to look at more affordable housing, to make sure that elected decision makers are educated and informed with health at the table, with equity at the table around what their decisions around what to fund and whether or not it's our direct, when city planners think about building, when economic development folks think about where they're, how they're zoning and what they're thinking about, how are we making sure that affordable housing, built environment, and food access are playing into are at the table. And it's not going to be something that we see change tomorrow. Some of these things have sort of long legs to them, and we're going to have to watch these outcomes and continue to push on these over the course through policy, through programs, yes, but really through policy and through how we can influence what gets put into, what gets built and what gets structured within city and county and other areas to change the default. I know it's very vague and it's hard for me to get all of these things into one. It's hard for me to put all of these into one bucket, but that's the overall goal, is to align these forces to impact policy and programming with a lens, not to just, for example, looking at, this is maybe not a great example, but looking at gun violence, where we see negative outcomes coming from gun violence. It cannot just be around pull away the guns, although that's important. It's also going to be around what are the areas, what are the either the ACEs or the environment that generated a situation where individuals are injuring each other. So how do we, minimize the impact of the trauma, minimize the trauma through housing stability, food access, et cetera, to do both. And that was very long-winded and probably too big, but try to get that.
I wonder if I can just sort of piggyback off that response and on some of the questions that have been generated in the chat to focus again on a lot of you or all of you highlighted how communities have mobilized or community has mobilized for mutual support. They're actually outside state efforts and or maybe parallel to. So we see this in the photographs, the depictions the content of the photographs, but also in the role of photojournalism and of art itself during an epidemic. Cheesy, you talked about how individuals, community organizations, and businesses offered necessary services, food, access to vaccines. John, you were talking about the creation of St. Stephen, for example, and Melissa, you were repeatedly underscoring community needs to be the driver for health systems and service response. So to bring this sort of concretely, how and what can VCU and VCU Health do, and how can they learn from these community responses in sort of concrete, practical, non sort of recuperating and just saying, oh, we're doing community things in the way that you were you're being a little critical of, I think, right, Regina? So what might that look like? We've all been down this road before many times, right? This isn't the first kind of crisis that's been taken up and sort of amplified and scrambled for funding that resulted from it, and then very little change after, not to sound really despairing, right? So how can this look different? How might VCU and VCU Health in particular, because this is one of the sort of goals of history and health, right? Is to rethink and learn from the Richmond community. So what would that look like, do you think?
I think it starts with, just the basics of building relationships and not assuming that people even want you to be there to help them. I think there comes this entitlement that just because you're the big VCU, you're the big hospital, you're the big people, you assume that other people want to come to you. No, they don't necessarily want to come to you because they don't trust you. They don't know you. They don't see people who look like them on the streets talking to them. So I believe like partnerships. It sounds, yes, it's kind of a broken record, but it needs to continue and intimate partnerships and coming to trusted sources like the Richmond Free Press. We've been around for 30 years, working with us and getting information out, which in some cases, yes, that is done, but but not just when it is supposed to be done, right? It needs to be done constantly. We shouldn't be fighting to have partnerships, to reach out, to have information, to go to small parts of the community that don't trust you, but trust us. You know, and the partnerships should be real. They shouldn't be reactionary. That's why just in friendships, we work on relationships. It's just so basic. And that's why I just don't understand. I mean, it's so basic. And we as individuals, we know how relationships work. So why doesn't this transfer? I mean, we know why it doesn't, but that's a rhetorical question. But so anyway, I could go on and on about that. But yeah, it gets me fired up just because I'm on the streets. I'm talking to everyday people, and people are scared. People are scared of VCU. People do still hold this like fear of VCU as being a place, or other hospitals or other people in the medical field. I'm not trying to beat up on VCU. So no, but you know, but yes, relationship building. I'm going to keep it at that.
Yeah, and also, just to piggyback off Regina, one of the reasons that the barbershops participated in the program with Richmond Health Department and Henrico Health Department, it was sponsored by Shea Moisturizer. And one of the things that they found in the Black community is that people trust the barbershops. They trust to come in, they trust the information that they receive. So when Shea Moisturizer initiated that program, they reached straight out to the barbershops, and it was a big success. And you know, for the health departments to come here, set up outside, to give the vaccine and to have information, because one of the things that a lot of people were receiving was misinformation. But they knew that if it was at the Black barbershop in your neighborhood, they trusted that.
And same here. When they saw things in the Richmond Free Press, they're like, oh, I saw it there, so I know it's good. Or like people will say, oh, we look on the front page and it tells me where to go for a test or for a vaccine. You know, also people are intimidated. They don't know how to access online. They don't, yes, everyone does have a phone, but to navigate the system to get to the phone number. I have sat with so many people on the street and navigated websites for people, for the health department, for VCU, for people. I've called for people I've met in the beginning to get in the beginning when people are trying to get tested, and told them where to go. You know, I felt like I was an extension of, but that's my job too, you know? So yeah, but yeah, Cheesy and I, we're on the same page. And Shea Moisturizer also, I mean, Shea Moisture, that brand in itself is a brand that is respected in the Black community, but from all demographics of the Black community. So from, you know, from different social classes, if we have to break it down like that, everyone knows that product. So that's the thing, go to someone that is trusted from all groups, because we are not a monolith, but there are some things that are trusted by all people, you know, or lots of people.
I would tag on to that I think that is one of the where I feel like a lot of good strides were made in some cases for us, at least for us in the health district, is that I found that we made, for whether it was the barbershop initiative or whether it was our faith communities, our faith leaders, that's a huge win, because it's very, at least it became very clear to us that where people trust is in their faith community or in the barbershops. Like we needed to be, or in the media that they look at, what media do they read? What news do they read? Where do they get their news? And to find, and again, exactly like Regina and Cheesy were saying, meaningful partnerships and connections with individuals who are already trusted within those communities is critical to maintain, to increase and continue. So, you know, we shouldn't just be here because of COVID. We're not just here because of COVID. It's unfortunate that people think that we're just here because of COVID. So how do we continue this, how do we continue to use our partnerships to make sure that people don't just think we're here because of COVID? We are here for other things as well. And part of it is connecting people. For example, maybe it's navigation. Maybe it's an issue of, like Regina was saying, do we need to navigate people if there are resources and there is funding or there is support, whether it's funding for initiatives, rental assistance, not just healthcare, but healthcare is another one. How do we help people navigate this kind of taxing and ridiculous system sometimes, what feels like sometimes, to get to their desired outcome when they just have 8,000 other things. So it's a number of different things that we already knew, but kind of need to, what gains we made through this pandemic, we just need to make sure that we continue and really sort of deepen over time to continue to be community engaged, because we shouldn't, if we lose this opportunity, if we just say, okay, it's COVID, we're done now, nothing is gonna change in the long run. So that's kind of a lesson that we learned, that we really need to, we are committed to living into, at least moving forward.
Thanks. So we have a number of other questions. The next one has to do with highlighting. So there's a longer version of this question, but I'm going to read the sort of condensed version, which is highlighting COVID-19 racial disparities can reduce support for safety precautions among white US residents. This is a recent article that was published. So the more discussion about racialized inequities have actually resulted, according to this study, in less concern about the disease and about the illness from white people. So do any of the panelists?
I have not read that article per se. I haven't seen that article myself. I would ask whether or not, I don't know. I don't actually have an initial reaction to that. I do think that people are tired of COVID as a whole. I think that again, I have not read the study. I don't know its methodologies. I would wonder how they are adjusting for the fact that everyone is tired. I'm sure well, I'd like to think that they are, that they're adjusting for that, but that COVID fatigue is real. It was real in 2021. It is even more so now. People are done with hearing from me. So I think I could see an argument for, perhaps, when you highlight it as a race-related issue, you may disengage particular elements of the population. But, to be fair, COVID doesn't care. It will impact people. It doesn't care what you believe. So I think that is maybe, and there may be a need to go back to that sort of, the racial disparities are because of these other issues. And COVID just made them worse. And so I think it's an interesting lens to think about it, in terms of, because we've been trying to mitigate them, that perhaps others have disengaged. But I would also say that people are just tired of hearing from me and from other public health experts and from anyone around COVID, in particular on mitigations.
Okay. Another question is, thank you for your presentations. So following Melissa Barre's description of the various ways that poverty exacerbates racial disparities, I'm wondering if the panelists might say, in their view, what would constitute equitable conditions of health and access to health, promoting and protecting resources? What kinds of institutional changes need to be made to create equitable conditions of health and access? Okay, sorry, that's the repeating. Okay, for example, what about passage of Medicare for all, or following Martin Luther King, a radical redistribution of wealth? So what would it look like for all people to enjoy the same health conditions and access to health resources as, say, tenure faculty at VCU?
I talk a lot. I want other people to talk to. But I think that's ultimately the goal. I don't know. I said I didn't want to, I wanted other people to talk and then I talked. The goal behind impacting the built environment, putting policies putting policies in place and putting programs in place to try and mitigate is to achieve equity, meaning everybody has the same opportunity so that the default choice. So for example, maybe it may not look like radical redistribution of wealth. Maybe it looks like intentional placement of grocery stores with affordable food. Maybe it looks like, affordable housing, more investment in affordable housing, and a shift in how we are structuring. Maybe it looks like paid sick leave. Maybe it looks like, I don't think it has to be one big thing, and it shouldn't be one big thing. And I feel like when you try to make these big, huge shifting changes, it becomes such a big thing and so complicated that no one ever wants to touch it. But there are so many smaller things that can look to, we're not looking to give everyone the same size shoe. We're looking to impact things like, we're looking to give people the shoe that's appropriate for them. And so it may not look like the same answer for all. It may look like in some communities, again, in some communities, it may look like a grocery store. It may look like increased commitment to green spaces, cleaner air in homes, building new, having building permitting that looks at having, accountability around what is acceptable in our housing, or in our homes, or and all of these different things. So it's a lot of little different things in these large areas of built environment and economic stability and economic opportunity that I think all come together to look to give people the right shoe for their foot. So I'm not sure that there's probably a long roster list of things. I'm not sure there's one, and I'm not sure it's going to be the same for VCU versus us at the health district versus the city of Richmond, Henrico County. It's going to look a little bit different for each, depending. That's just my opinion.
This is kind of a related question from the chat. So is there any effort to bring together government agencies and community groups working in these many areas, like housing, food access, health disparities, et cetera, on a regular basis, maybe monthly, so that there is a broader overview of what is happening? And so that question also relates to the comments that Cheesy and Regina were making earlier about conversations with community groups and members, right?
There is, I think, a need for both increased. I think one of the opportunities for us in health, not just in health, but one of the opportunities for us as a community is to work to align our different, I think everybody working in this sector, whether it be community-based organizations or government agencies, others, we're all looking to see the same things happen. We might see different ways to get there. We might be looking at different things and moving in different directions. I think there is an opportunity for us as a whole, as a community, to make sure that we're all working to be on the same, working to at least be aware of what's going on in the different parts. I know that that's not a new goal for this area. I think it continues to be something that we've been trying to see happen in the background, and perhaps could use a little more transparency around as we move forward, because that is work that we are working to see happen and see more alignment on. I think there's more to go, and we could just probably benefit from a little more transparency so our communities know that this is going on and that we are working on increased alignment and making sure that we're all at least in the same book.
This relates to the next question, which is, so by evaluating and addressing dis-ease, so that's a pun on disease, rather than access to disease as the approach, why is the healthcare community so mistrusted still? So I mean, this provoked some smiles from Cheesy and Regina. So I think maybe you can maybe help respond to this question about why there might be some resistance to, if there were to, these kinds of conversations are set up, by whom, that would be another question, but.
Yeah, because of history, because of experience. Let's just be, I mean, we live our lives based on experiences and relationships and the way that we are treated or mistreated. So, I mean, I'm just going to keep it simple. That's it. I mean, let's just think about it even, with, you talk to older people in the Black community of Richmond as it relates to like Chip Jones's book, right? And people say, oh, there's no way I will go to MCV, even to this day, because of these are older, people. And then that's passed on because they know like, oh no, you go into that hospital, you won't come out. And, then you have to say, no, but things have changed. I mean, but people, this is ingrained in some people's minds, and you cannot just erase history. You cannot erase pain and trauma. You cannot erase it. It is a process that it's ingrained in us. We all have this intergenerational pain and trauma that has been passed on. And even if intellectually you can understand, you still, even me, I still have certain things that like I twitch about and, and I'm like, ooh, and I have to question. But imagine someone else who they don't have all the access that we have to information, and all they know is what's happened in their family. Like Melissa, Dr. Veray mentioned about, let's say that one family that has lost a mom, a grandma, a son, a cousin, the friend across the street. What are they gonna, I mean, yeah. So history is the answer, and we gotta build on that. Yeah. Yes, Black Richmonders still remember the night doctors. Yep, many do. And even like, there's a Black hospital, the hospital on Overbrook, that sits empty. I think it was a private hospital where a lot of people were born, and that sits empty. And how does that make someone feel when you drive by that hospital and it's empty, it's dilapidated, community hospital, and it's just sitting there, and people say, oh, I was born there, but look how it looks now. So that in itself shows people that building's not even cared for or cared about. The place that I was born or I was treated. I mean, all those things translate. Am I making sense? Visually, that's like, well, they don't care about that building where I was born and where I was treated and my grandparents were treated. So why do they care about me? Why do I trust the system?
We have a time for a couple more questions. So COVID has been and is still a mass disabling event. Are we seeing any movement yet towards addressing the ways in which racialized health disparities might also translate to a greater proportion of post-COVID disability amid Richmond's Black and Latinx communities?
I think that's a really timely question. The question's about long COVID, and I think there are still a lot of unknowns around what long COVID means and what it's going to mean in particular if we have a higher proportion of folks in our communities, of our brown and Black communities who had COVID. Are we necessarily going to see perhaps a larger proportion impacted? That's a really good question. I think we are still trying to understand what long COVID how that's going to play out over the long term. I don't know that I have seen as much in the way of, I guess what I'll say is, I think my answer to that is less directed at specifically long COVID and more at, it just speaks to me more about the need to get at those inequitable issues, because it's going to play out for even longer than if we have those existing inequities. Again, the same inequities that existed that became worse with COVID. It really just heightens for me the need, because there may be a risk for long-term in disproportionately brown and Black communities, disability and or impacts. It just speaks to the need to be to even more robustly approach those pre-existing conditions, those pre-existing conditions that promoted inequitable outcomes.
So there was an article published in 2015 or 2017 that showed over 50% of the LGBTQ population in Virginia, especially the transgender population, would delay seeking medical care, even in a life-threatening situation, due to a combination of discriminatory treatment from and lack of knowledge in healthcare providers. As a transgender woman, I can say that while these conditions have improved, I still struggle with seeking healthcare unless I know I can see a provider who I've seen before and know is accepting of the transgender population. Ms. Farmer touched on this topic briefly. I know there has been a great deal of focus on racial disparities through this pandemic. What sort of impact do you believe the disparities have had on the LGBTQ population? So I think the question is, how have racial disparities been intensified for communities of color that are also LGBTQ, but I might be misreading the question.
I have an opinion, but it might not be answering the right question. And I also feel that I am not the expert in the room. The community is. So, but I think but I would say that I think one of the things that lack of cultural competence with regards to our LGBTQ community means is that their plight is silent, and that they are not as, it is not as easy to detect those inequities, because we don't even, unfortunately, we don't even have culturally competent forms. We don't even have the ability. So pre-existing, even before COVID, we, how we count things, how we count race, ethnicity, still a delicate and not very, I have issues around, how we count race and ethnicity, period, within, the census and things like that. Putting all that aside, we don't have culturally competent, speaking to the LGBTQ community, genders. And so it makes it even more difficult to understand the problems that they are seeing in that community, because we are not even acknowledging them and saying, we know that you're there. We want to be able to say what your, are you having difficulty accessing testing? Are you having, because so why would they tell us what their experiences is? Because we don't even have we ask them, oh, you're coming to get tested, are you male or female? Thanks. So I feel that it is not because, this is maybe not the right way to say it. I feel that we are not as evolved with regards to our LGBTQ population, both in how we treat them within the medical field, or how we approach them, or how we make sure that our healthcare providers are competent to not alienate folks with how we address folks who, how we address folks from that community. Our forms don't even let us reflect that. Our forms sometimes don't even allow us to count people as, you don't have to be male or female. And so when we don't even give them a place to be counted, it's hard to say exactly how bad it is, other than to know it's probably not great. And so it's something where I think we need to, and it is something that we are looking to address further, we being the larger public health I just feel that it's not evolved as much as we have for race ethnicity. And we're still addressing issues in race ethnicity, but we have even further to go, I think. And so that impairs our ability to know just how much the gap is, just that we know it's there. Sorry, go ahead, Chizzy.
Yeah, there is one particular organization that I do know that is out there called Nations Foundation that is really, really trying to help the Black trans community. And of course, even their resources are limited because of the environment that we live in. Even some services that we would need here in Virginia and can't find in Virginia, people have to travel outside of the state to get. But I do know that Nations Foundation is one of the best resources that I know of that could help and navigate the Black trans community. So I just wanted to let them know that that's one resource that I know that will help you. Zakia is, she used to be with the health department, so she's a good resource.
Okay, so another question. I wonder, Dr. Bure, if it is deeper than giving the appropriate shoe or resources, but ensuring that folks are not prevented from accessing vital resources because of systemic issues of bias, discrimination. I know folks get tripped up with the concept of, quote, giving resources to our most vulnerable and would only take that from your quite ample response.
Probably both ends. It's a lot harder to put a pin on that, but I think it's about helping people to understand. Our hope maybe is that to help people understand what the concept of the right shoe, so that there is not the objection to giving resources or providing resources. It's not as easy to say. It's a little bit of both, and I suspect is maybe the shortest answer for that.
Okay, we have a number of comments in response to prior comments. So Black Richmonders still remember the night doctors. Even today, people see how VCU and VCU Hospital respond to what has happened. Transplants, stealing Black bodies from cemeteries. They need to see a much stronger level of apology and what they are doing to atone and change what happens today. So 100% Regina, history lives, breathes, and reverberates in the present. But what if going into the future, we approach it differently, presuming that for the most part, people want the same things? Oh, do people want mostly the same things? Okay, but okay, I disagree that we should approach the issue from a negative historical perspective. I was born at St. Philip's, attended MCV School of Nursing, and practiced public health nursing for years all over the country. History is important, but what if, quote, poverty and disadvantage, close quote, are more critical determinants than race?
That's a whole panel discussion in itself. That's all I can say. I'll leave it at that. That's a whole panel discussion.
I mean, I can wade in and just say, I think it's impossible to talk about poverty and disadvantage without talking about race.
Exactly.
Poverty and disadvantage have been racialized from the inception. So, and I would be skeptical of people who would try to extricate the two and say it's not about race. I would wonder what the motives would be in trying to separate out race. If it's trying to, actually, I don't even want to speculate. I would insist on always centering race in the discussion if you're talking about poverty, disadvantage, health inequities, inequities more broadly. It's impossible not to in this country and globally, given the history, right?
Exactly.
So I don't know. That would be my perspective.
And I
but
agree with
ask.
that total. And that's where I stand too. But like I said, I think we could, obviously there's various perspectives to that. So that's why I was saying that could be a panel discussion unto itself, but definitely I would, like you said, I would be skeptical of anybody who would want to have that discussion without race being in that conversation. It's impossible.
Interested in learning more. Okay, so we maybe in our last few minutes, One last question. We know intersectionalities make disparities even worse. The LGBTQ plus community endures many barriers. I am sorry for this. I am committed to making changes within my sphere in the medical community. Our new medical record has improvements over the old one for the LGBTQ plus community. I would love to hear experiences and what would help. Would it be helpful to have some way of indicating providers who are accepting, who are experienced?
I wonder if it's also a little bit word of mouth. I think it's certainly never, I can't speak for people. I don't want to assume that it would or would not help. I certainly think that representation helps. So having, and where you can't have representation yet, having, as long as you're living into it, overt representation of the fact that you are looking to support a community, I think is great, as long as it's echoed in the actions. But I do wonder how much is actually just word of mouth too. I went to this provider and they were awesome. You know, that's probably going to mean a lot more than anything else. But I would be overstretched. I would be speaking for others where I shouldn't otherwise.
There's a helpful resource in the chat. The chat has actually been a source of some great referrals. So we'll try to get that information out to people. There's going to be a record of the chat, and then we can cut and paste and try to provide that to people. I think that's all we have time for today. I just wanted to, before Logan gets on, I think, and closes us out, say thank you so much to the panelists again for such a rich and thoughtful discussion on what are often, hard topics. And I appreciate your frankness, your time, and your the passion that you bring to the topic. So and the questions. So thank you so much.
Yes, and I would just echo that and thank you, Chris. You've been an excellent moderator. We appreciate everyone's time today, especially the audience who's had such wonderful questions in chat and Q&A. This wraps up our season for History and Health, but we are looking forward to, as Christina said, having a symposium in the fall and more programming as well.